Welcome to this explainer. You know, the trauma bay is basically the definition of chaos, right? Well, today we are looking at how that intense, high-stress environment gets transformed into a sleek, high-tech checklist using something called the eFAST protocol. We're going to explore exactly how the noise and urgency of acute care are distilled down into a visual, step-by-step process that you can use to make rapid, literal life-or-death decisions. Because when you're standing next to a hemodynamically unstable trauma patient, where time is quite literally tissue, this is the absolute most critical question you have to answer. Does my patient have free fluid? You can't just wait around for a CT scan. You need eyes inside the patient right then and there, and that's exactly what ultrasound gives us. The ability to instantly spot anechoic or dark black free fluid that's hiding in the body's potential spaces. So here is our roadmap for today. We'll start with 1, the eFAST revolution, then move to 2, prepping for the scan, 3, the 5-step protocol, 4, identifying critical pathologies, and finally 5, the clinical algorithm. All right, let's jump into section 1, the eFAST revolution. To really appreciate this tool, we have to look at how fast things have changed. Medicine went from just checking the abdomen back in 1996 to a much more comprehensive protocol in 2004. Thanks to some landmark studies, researchers proved that ultrasound could reliably diagnose pneumothorax, hemoperitoneum, and pericardial effusions. So the extended FAST, the eFAST, was born. By incorporating the heart and lungs, we finally got a complete picture of both thoracic and abdominal trauma. Moving right along to section 2, prepping for the scan. Before you even touch the patient, setting up your environment is absolutely non-negotiable. You've got to place the ultrasound machine on the patient's right side. Why? Because this lets you scan with your right hand while seamlessly tweaking the machine controls with your left. The patient should be supine, and if you can, put them in the Trendelenburg position. Tilting them head down slightly actually increases your chances of spotting fluid. As for your probe, a phased array is perfect for the whole exam, though a curvilinear works great too, just as long as it can squeeze between the ribs for those cardiac views. Which brings us to section 3, the 5-step protocol. This is the core action right here. The protocol builds a clinical checklist across 5 distinct anatomical zones. The goal is maximum efficiency, doing the exam the exact same way every single time so nothing slips through the cracks. Let's break down each step. Step 1 is the right upper quadrant. Since the liver is the most commonly injured organ in blunt abdominal trauma, this view is incredibly sensitive. You anchor your probe at the 10th intercostal space at the mid-axillary line. Here, the liver acts as your acoustic window. It's basically a clear lens for your sound waves, allowing you to spot dark, anechoic fluid hiding out in Morison's pouch, right between the liver and the right kidney. Step 2 takes us to the left upper quadrant. When you transition over here to the 8th intercostal space, you literally have to drop your knuckles to the bed. The spleen is your acoustic window for this side, but it sits pretty far back compared to the liver. Your focus here is the perisplenic space between the spleen and the diaphragm. Interestingly enough, there's a splenorenal ligament that actually blocks fluid from easily flowing between the spleen and the left kidney, which is why we target that perisplenic space first. Step 3 brings us down to the pelvis. Now, what's really fascinating here is how fluid accumulation shifts based on biological sex. For male anatomy, fluid tends to pool in the rectovesical pouch, but in female anatomy, it gathers in the rectouterine pouch, famously known as the pouch of Douglas. To get a good look, you use a full bladder as an acoustic window, placing the probe just above the pubic symphysis and fanning left and right to thoroughly sweep those potential spaces. For step 4, we move up to the heart. Ideally, you want the subxiphoid view, pressing the probe into the abdomen right beneath the sternum and aiming the beam straight toward the patient's left shoulder, using the liver as a window again. But, sometimes the patient is in too much pain or their body habitus just won't allow it. If that happens, no problem, just pivot to your backup, the peristernal long axis view at the 2nd or 3rd left intercostal space. Ultimately, you're just trying to make sure dark fluid isn't choking off cardiac filling. Finally, step 5, the lungs. You place the probe at the mid-clavicular line in the 2nd intercostal space. But to know you're in the exact right spot, you have to look for the batwing sign. It's this very distinct visual of 2 dark rib shadows flanking your image. Seeing those wings confirms your probe is perfectly nestled between the ribs, giving you a crystal clear view of the pleural line. Now that we know where to look, let's hit section 4, identifying critical pathologies. Keep this crucial clinical pearl in mind. If you see black fluid in the pelvis, it does not mean the bladder is ruptured. It just means there's bleeding somewhere in the abdomen. Free fluid flows with gravity, right? So the eFAST is amazing at detecting the presence of hemorrhage, but you're still going to need a CT scan later to pinpoint the exact organ that's bleeding. Let's check above the diaphragm. The contrast here is super helpful. In a healthy, air-filled chest, the lungs scatter your ultrasound waves, so you won't see the spine above the diaphragm. But if that chest cavity fills up with blood, a hemothorax, those sound waves pass straight through the fluid. Suddenly, the bony spine becomes crystal clear right above the diaphragm. Seeing this positive spine sign effectively diagnoses a hemothorax. Back to the heart. Spotting a dark ring of fluid, a pericardial effusion, is a big deal, but it isn't quite enough on its own. You have to figure out if that fluid is under so much pressure that it's actually crushing the heart. Watch for the trampoline sign, which is early right atrial systolic collapse. And if the right ventricle starts collapsing during diastole, that's highly specific. It means you're looking at true, life-threatening cardiac tamponade, and you need to intervene instantly. Next up, the hunt for a pneumothorax. When you're looking at the lungs in standard B mode, look closely at the pleural line for a visual metaphor we call ants marching. This shimmering effect is just the normal sliding of the visceral and parietal pleura against each other as the patient breathes. If you see the ants, a pneumothorax is 100% ruled out in that specific spot. But if the ants stop marching and that line goes completely still, you better suspect a pneumothorax. To get even more precise, flip your ultrasound machine to M mode to capture motion over time. A normal, breathing lung is going to paint this beautiful seashore sign. The straight lines are the motionless chest wall, like the sky and ocean, and the sandy, granular area below is the moving lung. But if the lung is collapsed, there's zero motion. Your entire screen is going to flatline into harsh, stark horizontal stripes. That is the dreaded barcode sign. And here is the absolute gold standard for diagnosis. As you slide the probe across the patient's chest, if you can locate the exact geographical spot, the lung point sign, where the sandy seashore immediately snaps into a rigid barcode, you found the literal edge of the collapsed lung. Seeing this transition rules in a pneumothorax with 100% certainty. No guessing required. The source material also drops a really cool pro tip, especially for penetrating trauma. If your abdominal views are getting totally washed out by repeating bright echoing airstripes, don't just blame poor technique. Be highly suspicious of pneumoperitoneum. That's free air in the abdominal cavity, presenting as the enhanced peritoneal stripe sign. Okay, let's wrap this up with Section 5, the clinical algorithm. So, what do we do with all this visual data? We turn it into action. If you have a patient who is hemodynamically unstable and their eFAST is positive, the surgeon now knows generally where the bleeding is, abdomen, chest, or heart, and can plan their surgical approach right away. But notice that bottom row. A negative scan on an unstable patient does not mean you're off the hook. The eFAST usually needs about 200 to 250 milliliters of fluid to even show up as positive. So if it's negative early on, you have to pivot to a CT scan if they stabilize, or keep doing serial eFAST exams, because as we know, significant bleeding can easily be delayed. As we conclude this explainer, it's pretty incredible to think about how wielding this rapid visual tool cuts right through the chaos of the trauma bay, empowering you to instantly identify life-threatening injuries. It really makes you wonder, doesn't it? How many other chaotic areas of medicine could be completely redefined if we just let sound waves guide the way?